Thank you very much for the introduction, Doctor. So, can I have the, okay, it's projecting now. So it's with a pleasure that I'm here today, even mostly virtual to those who are not in the room. I'm very delighted to speaking to you about what we think of outcomes of COVID-19 in ICU challenges and solutions. As a matter of fact, if we would want to, how does it go forward? By the arrow? Okay. If we would like to address the challenges and propose solutions to patients with COVID-19 or hospitalized COVID-19, specifically those in the ICU, we got to understand that the spectrum of the treatment or management is very, very broad. And it has many, many of these elements, starting from oxygenation, ventilation, viral pneumonitis, cytokine storm, treatment, thrombosis, multi-organ failure, secondary infections, rest of typical ICU issues that would happen with COVID and non-COVID patients. And parallel to that, in the far right, I have put in infection control, their vaccination status at any stage, as well as ward or the ICU design, where you have put it together. For the sake of time, I would be covering those highlighted in the green, and then we will talk about what the typical management and where the dilemmas related to treatments are, and then that may reflect the true challenges to what we're facing. So this is a typical course of critically ill COVID-19 patients. From the very beginning, it usually evolved around day 10 to day 12, when they would require the hospitalization or they would require an ICU stay. And if it happens that they would require the ICU, they are very unlikely to leave the ICU in less than 7 days. They either die quickly or they were likely to hang on for a week. And then was in the very beginning of the pandemic. And then at a later stage, the ICU stay took longer because we're giving some therapeutics which keeps patient hanging on with life for a longer period of time, which leads to further complications. So starting with oxygenation and ventilation, these are different modalities. Maybe they're so much known to the intensivist, but for the general practitioner, this may sound like a good reminder to know that this is nasal cannula, and below each shows you how much of a flow and FiO2 can be delivered by this oxygenation modality. So nasal cannula give you 0.5 to 4 liters, FiO2 22 to 32%. Then the face mask give you 6 to 10 liters, maybe 40 to 60%. Then the nano-breathing mask could deliver even up to 95% of FiO2 if it is delivered at 10 to 15 liters. Then there are the high-flow nasal cannula, which had been very popularly seen during the COVID-19. You may see it in ICUs or even on TVs now, that it shows can flow up to 60 liters per minute with an FiO2 that can be even 100%. Then there are the non-invasive mechanical ventilation. It comes in two formats, with BiPAP, CPAP, or those with the helmet BiPAP, like the one shown in the photos. They usually give good amount of oxygen, FiO2 up to 100. And then they give you even varieties of some pressures. Then finally comes the invasive mechanical ventilation. And this is like a turning point in the care of COVID-19 or any ICU patient. This is the machine that would be hooked in through an ET tube that goes through via the larynx into the trachea. It delivers a flow up to 60 liters per minute, variable pressures, and all percentages of FiO2. But it's extremely essential to keep in mind, like I said, this is a turning point, because the moment mechanical ventilation is placed, a lot of challenges comes with it. And number one is the instrumentations associated. So just hooking up the patient on a ventilator, you're likely to acquire, or the patient likely to acquire, a central venous catheter, an arterial line, Foley catheter to be in place, arterial line, beside an nasogastric tube to access the stomach for medication and feeding. And these are the medications likely to be associated with the ventilator, including sedation, analgesia. There could be some compromise to hemodynamics because of the positive pressure, which will bring along maybe vasopressors or IV fluid. Now we're told by Bendels to put PPI on board and anticoagulation prophylaxis because of mobility related to others. And not only that, the ventilator, despite the merits it gives, it can bring about complications, some of which may be also life-threatening. As simple as endotracheal tube blockage may be a translation to an instant death, or maybe translated to an instant death. There could be pneumothorax, which may not be given enough time to revive a patient. There could be also subcutaneous emphysema, hemodynamic compromise. There is the typical ventilator-associated pneumonia, or even if the ventilator is not handled well in its pressures and FiO2, patients may suffer from ventilator-induced lung injury. There is also that dependence on the ventilator, especially with diaphragmatic dysfunction, with muscle weakness, and then people may become ventilator dependent for long. Other than those medical issues, when patients come in a surge, we'll have to consider another important factor, which is a new challenge, that is the cost. This is a study that looked into Saudi Arabia during COVID-19 and found that on the average, there were 7,810 Saudi riyals per admission for COVID in the ICU per day. But once mechanical ventilation is added on, that number jumped into 11,215. So significant difference in the cost, just the fact that mechanical ventilation has been placed on the same ICU patient. So what also challenges the intensivists during COVID-19 is the thinking of when to intubate. So the decision to intubate had been varying along the pandemic timeline. In the very beginning of it, we were very liberal because this was a new infectious disease entity. We don't know what it is. We'd like to host patient on a closed circuit, and then we feel safe from the patient towards the healthcare workers. Later on, we've realized there is a lot of burden. When you intubate more people, you have to care for them. You have more nursing staff to do so. And then also the venue of the hospital make you decide how you want to go about it. Like local practice circumstances. If there are patients who are on the floor, you might be better off putting on a ventilator because you can't really monitor their work of breathing in comparison to somebody whom you watch in the ICU more frequently. Modalities has come along with while we're treating for COVID patients, and then patient compliance to self-prone positioning, and there has been data supporting that practice, and those who are not compliant with that may push themselves toward an early intubation compared to others who would otherwise comply. But generally, we agree that recommendations to intubate would be when there is a rapid progress over several hours, lack of improvement on more than 50 liters per minute on high flow, or when the inspired oxygen is more than 60%. When there is an evolving hypercapnia, increasing work of breathing, tidal volumes, and so on, will mandate doing so. Certainly, hemodynamic instability will give the patient the comfort, and the healthcare worker or the intensivist the security that the patient is grabbed well when he is on a ventilator while caring for other disease parameters. And then as time elapses and the patient hopefully is toward recovery, then things may be rethought about. This is what a typical ventilator setting is advised to, but there is nothing different about it. In fact, this is what we followed with the ARDSNet protocol. I know there has been a lot of debate about what's the best way to ventilate COVID patients. There has been many opinions and suggestions, but we ended up at the end of all this, thought that ARDSNet protocol is what we've been following, and that's good enough and safe enough to the majority of those with COVID-19 patients. There is nothing so specific about them per se at the end of that long discussion. What is beyond regular mechanical ventilation? Those who fail to attain a good response to the mechanical ventilation, or they happen to have low tidal volume or fail of low tidal volume ventilation, then we would do proning to some, recruitment maneuvers to others, maybe inhaled nitric oxide. There could be neuromuscular blocking agents for those who are refractory hypoxemia or major desynchrony, and possibly ECMO. Now, you may do some or a combination of those to some patients, or you may have to change one. You may want to try one thing, remove it, and try the other thing. The problem is we don't have a clear guidelines on which modality would work for which patient. It is the experience of the team handling and caring for these to know which modality of those would work. And also, I would like to alarm you that these modalities vary also in their evidence. A lot of them may not even change mortality altogether when they were studied, but it has given the intensivists some time to catch up and the patient some healing time and recovery for their lung disease until things get better. What was more studied during the COVID time was the ECMO. And then without having to say much about it, this could be a lecture by itself. ECMO is a very sophisticated, and ECMO stands for extracorporeal membrane oxygenation. It's a very sophisticated way of oxygenating patients. But the principle is similar to dialysis in the sense that you establish an artificial lung outside the body. You take the blood from patient, oxygenate it, bring it back to patient, and then you load the ECMO, rather loading the lung to oxygenate. And then same thing to ventilate as well. So this is just a bridge to buy time until the lung heal and then make things easier. Mind that ECMO is very technical, it's expensive, it has limited availability, it's not everywhere that's present. Even if it's present, it requires expertise to be able to handle it. And then also there are transportation challenges to people who are hooked on ECMO and then to care for them. So now from oxygenation and ventilation, I take you to the next parameter, which is viral pneumonitis treatment. There has been a bunch of medications since the pandemic has been looked into that I have put them in red. They have never made it to be approved for use of COVID-19 patients. Only remdesivir plus minus baricitinib has been variably approved. It has been approved in the United States of America, many European countries, but there's still some debate from the WHO about its utility. In general, remdesivir found its way to the guidelines in many of the GCC countries, including Bahrain, Kingdom of Saudi Arabia, and other neighbor countries too. And then because it's available in America and other countries, and there have been some studies supporting it, it has been used. What made the evidence toward remdesivir was one of those. This is a study labeled Adaptive COVID-19 Treatment Trial, or ACT-1. And here they have compared remdesivir and placebo for remdesivir for 10 days or placebo for the same duration in COVID-19 patients. And then here they were looking at the primary outcome of time to recovery. So whenever the patients, as you see far on the right of the slide, whenever where the patient fits 7, 6, 5, and 4, whereby he requires some oxygen modality, and once for 1 day, he became among those in the green where he does not require oxygen, that is considered recovery. So what were the findings here? There was a difference of 5 days in the endpoint, which is median time to recovery, and there was a secondary endpoint, odds to improvement by day 15. So the shorter time to recovery from 15 to 10 was an increased recovery rate of 29% compared to placebo. And remdesivir produced 50% increased rate of clinical improvement by day 15. It did not overall show difference in mortality, but it shows in subgroup of them those who are requiring low flow oxygen. It also showed, especially among those requiring low flow oxygen, i.e. when it is given early, it could make a difference to make people decrease their disease progression significantly, and then possibly avoid the need of mechanical ventilation, which is a major aim, in my opinion, after the discussion that I have just given the past few minutes. This is when I was trying to allude to reduce mortality in some patient population. It was mainly on those at low flow oxygen. But the overall ACT-1 study did not show a mortality benefit, nor to say that it was not even designed to empowered to look into mortality. So what about baricitinib? So baricitinib was added to remdesivir in this trial, which is ACT-2, or remdesivir alone, and looking at the primary outcome. And the time to recovery was a difference of 1 day. And it may sound not so significant, but it was statistically otherwise significant. And then specifically among those patients who were requiring high flow oxygen, the addition of baricitinib to remdesivir made a difference. Baricitinib 10 days versus placebo of 18 days when looking at time of recovery. And that's why, including the national protocol of Bahrain, you see baricitinib is being added in the last version. It is present in the last version of the MOH of Saudi Arabia as well. The cytokine storm also have happened its share of many medications that have been studied to allude to it. And then what was so much in favor of it, or in favor of treating it, were either low-dose dexamethasone in the recovery trial, or the tocilizumab, which is IL-6 receptor blockers. So this is the summary of the recovery trial from University of Oxford, the most important of which that they found with 6 mg per day for 10 days, IV or oral of dexamethasone. Dexamethasone reduced death by 1/3 in ventilated patients, 1/5 in patients receiving oxygen only, no benefit among those who required none, which means non-oxygenated people not requiring oxygen are unlikely to benefit from dexamethasone. And death prevention is 1 in every 8 mechanically ventilated patients and 1 in every 25 patients who required any oxygen modality supplementation. The other one is tocilizumab. So the conclusion in the recovery trial also was in hospitalized COVID-19 patients with hypoxemia and systemic inflammation, TUSI improved survival and other clinical outcomes. Benefits were seen regardless of level of respiratory support and were additional to the benefits of systemic steroids. So whoever would receive TUSI is supposed to be receiving steroids as well. And then what is the optimal use of TUSI? It has been, may have a mortality benefit for a subset among the sickest among those of COVID-19. The best timing to do so, as per the recovery and REMAP-CAP trials, were with dexamethasone, so never alone. Obviously, it makes sense because once they start to use oxygen, you're going to give dexamethasone. The time you decide to give TUSI, they have been already 1 or 2 or 3 days on dexa. With marked elevation of C-reactive protein, the least should be 75. Would plan to use it for progressive respiratory failure and start within 24 hours of escalating organ support, usually when it is NEF or high flow or mechanical ventilation. So really about TUSI is the timing, and that would require intensive care to watch carefully and within a moment decide that the TUSI needs to be initiated. Rather the regular morning rounds when the opportunity may come and pass, and then you would give TUSI. You will get some improvement, not as much as when you have given it really upon escalating hypoxemia. This is a meta-analysis looking at the mortality and recovery and other trials. Somehow they have been variable, but since the biggest trials, including recovery, is in favor of it, it has skewed everything toward favoring tocilizumab treatment for cytokine storm. And lastly, we talk about ward or ICU design. You must have seen or lived this time with everybody else. This is, for example, the parking lot of Bahrain Defense Force Hospital when it has moved and changed into an ICU. So the idea of cohorting patients is to save, to concentrate the care, to limit the traffic and limit access, to segregate the COVID from non-COVID patients, and then it also to protect the healthcare personnel. This is an example of a field ICU in United Arab Emirates, and it has been the case in many other places too. So I would conclude by saying outcome of COVID-19 in ICU depends on care that is usually meticulous, it's continuous, and it has to be delivered by the most expert. This is not the time where people would train there. In fact, it's a great opportunity to train, but they need to be led by a very experienced intensivist because they are very meticulous and needs to be tactful. Applying principles of critical care medicine holds the true, whether in COVID or non-COVID. There is nothing so particular about COVID except that it's too much. Different oxygenation modalities may help in reducing need for mechanical ventilation. Need for the ventilator is a turning point in care for COVID-19 ICU patients for many reasons, some of which I have mentioned. And the care of it is not different from other ARDS patients. You just need to continue with that good care and continuously. And ECMO may be the last resort of oxygenation. As far as other treatment modalities, remdesivir may shortens hospitalization, decrease disease progression, may reduce mortality in a subgroup of patient population. Corticosteroids reduce mortality among patients requiring supplemental oxygen. Tocilizumab is an effective medication for cytokine storm. Best outcome is with optimal timing. An overall poor outcome of care, in my opinion, likely to occur from surge of patients because that may flip the equation. You're good when you have 1, 2, 3, 5 patients. When you get 7, 10, 15, 20, then you get skewed. You can't hold on anymore. Lack of preparedness, and many people got one wave after the other, and they're still struggling from the previous wave. They never managed to prepare themselves well to the next. There was that fear among healthcare personnel before vaccination, and I think that has significantly affected the care for COVID patients. And then finally, staff burnout This is something we're seeing. I have to admit I'm one of them, and many of us are really burnt out from all this time. I would like to thank you very much here, and I'll be very happy to take any of your questions. Thank you.